And before I introduce our board president, I wanted to talk a little bit about some housekeeping for the webinar, and then also to recognize some of our sponsors. For the webinar, we will be doing questions and answers throughout the webinar. So you'll notice that there's a chat feature, and as questions come up in your mind, just put the chat feature, open that up and put your question in there. And then our moderator will fill those and get them answered either during the webinar or at the end. But before we get started with a few introductions, I wanted to thank a couple of our sponsors. And what I want to do is we'll have kind of a clear the stage so that we can give the stage to our sponsors so that they can have a few moments to say thank you. So I'll introduce Carl, and then we'll turn off our cameras. And Carl, if you could say a few words from Dynavax, and thank you, Carl, for being here.
Thank you, Scott. I really do appreciate the work you do, the great work in the community in San Diego. It really is a pleasure to have Dynavax giving us the opportunity to sponsor this series of education webinars. Thank you to Dr. Sweet for volunteering your time.
Sure.
I've had a chance to interact with so many people at the Liver Coalition, and it's just so wonderful to see how dedicated to the community they are. As many of you may know, Dynavax, we have a brand new adult hepatitis B vaccine, which is just 2 doses over 1 month. The first time there's ever been a Hep B vaccine for adults that you can complete in just a month. And we actually have the foundation of our company that started in San Diego at UCSD. So it's kind of like this is our hometown. And as I said before, it's really a pleasure to be a part of this. Thank you, Scott, for this minute or two just to express that. And I'll turn it back over to you. Thank you.
Excellent. Thank you so much, Carl. And also tonight's second sponsor and supporter, Elena, thank you so much for AbbVie for being here and for all that you do. And I know that you've got a special video. I don't know if you want to say a few words to tune it up, or we'll just have Lori show it.
I'll say a few words. So thank you for having us here. You know, AbbVie's committed to curing Hep C. We are the only company with a treatment that's pan-genotypic that only takes 2 months for a full cure. So really exciting for us to be really the pioneers in that and leading the way for shortened treatment duration. And I just wanted to have a short video shown to really show AbbVie's commitment and what we bring to the Hep C population. So thanks, Scott.
Excellent. Thank you, Elena, and thank you, AbbVie, for being here. At this time, you've heard my name mentioned a couple times. I'm Scott Succo, and I'm so pleased to be your executive director for the Liver Coalition of San Diego. It's my pleasure to introduce our president of the board, Terry Cunningham, to say a few words about the coalition and our mission and focus. Terry.
Hello, sorry about that. I couldn't get it unmuted. Welcome to another one of our webinars in our series dedicated to liver diseases and what you need to know about your liver. The Liver Coalition of San Diego was started last year, actually, late last year, after the American Liver Foundation decided to discontinue their offices here in San Diego. And several of us got together and decided that we needed to continue the work that was being done so that people with liver diseases or with questions of liver diseases would have some place to go to find out the answers to their questions. We're very pleased that these webinars have been going over so well. Many people have commented on their excellence, and we hope that if you have questions, you'll ask them. And if you need more information, please go to our website and check out the various webinars that we already have done. And there will be more coming down the pike. So check the website to see what the different topics are going to be. So thank you again so much for being here, and enjoy the webinar. Thanks.
Great, thanks, Terry. And I'll go ahead and introduce our moderator for this evening. And our moderator also serves as the co-chair of our Associate Medical Advisory Committee. And Shirley Sanuda is a pharmacist at UCSD Skaggs School of Pharmacy, is a leader for the organization, and has just been an excellent addition as a voice in fielding our questions. So Shirley, thank you so much for being our moderator and for joining us this evening, and you'll introduce our speaker for tonight.
Thanks, Scott. So welcome, everyone. It's my pleasure to introduce Dr. Patrick Sweet, who is a staff hepatologist at the Southern California GI and Liver Centers here in San Diego. And he's going to talk to us today about our liver function test. Dr. Sweet.
All right. Thank you for introducing me. So let's see, can you see my lecture at this point?
Yes, we can see
Yes.
it.
Excellent. All right, so like she said, I'm with Southern California GI and Liver Centers. My clinic is actually out in El Cajon, which is in the east county of San Diego, for those that don't know where that is. And we see quite a bit of liver disease, our fair share of GI as well. So I'm excited to be here, honored to give this presentation. Liver function tests are sort of a very broad topic. So I figured I would cover a little bit of the anatomy and physiology, because understanding some of these tests, you sort of need to understand some of that. And I bet that, you know, we could all use an overhaul, or at least a reminder if you do know this stuff of anatomy and physiology. So I figured I'd start with that. So here's kind of a generic view of the liver. There's a left lobe, a right lobe that's visible. You see a gallbladder there. The liver is a unique organ. It receives essentially two blood flows, two sources of blood flow going into the organ. One of which is a typical artery, the hepatic arteries, and then the other, which is not a typical artery, which is the portal vein. Although it's a vein, it's actually supplying most of the blood to the liver when you compare it to the arteries itself. And the blood that it's bringing in is blood that's already been passed through other organs. And in this case, the spleen, as well as some of the intestines, you know, from the stomach all the way down to the rectum. And the way that this is fascinating is that if you look at it at a macroscopic level, and this is why I like this illustration, you'll see that the vein, the portal vein, and the artery are paired all the way into the liver. And you also see, if you look closely, that the green labeled bile ducts are also positioned with those same vessels. And that combination of three vessels is called the portal triad. And you see it right on the outside of the liver, where you see the portal triad right here. And then you see it on the inside of the liver up here and at different places. And this configuration of these three ducts or veins or arteries is seen throughout the liver all the way down to the microscopic level. And you can see it here. If you look at A, let me walk you through this. We have the portal triad again. So this is if you're looking at it under the microscope. There's a portal vein, there's a bile duct, and there's a hepatic artery. And what takes blood away from the liver back to circulation, if we look back again, is the hepatic veins. Those take those back, that takes blood that's been filtered through the liver in this first pass back to the heart and general circulation. And so that's also mirrored here in what we would call the functional unit of the liver. And so every central vein that we see, if you look at it under the microscope, is fed by essentially 6 portal triads. And what's positioned between these portal triads and the central vein are the hepatocytes. And if we look over here at B, you'll see the portal vein feeds in, the hepatic artery feeds in, and there's something called a sinusoid. The blood passes through that area, and as it passes through, it interacts with these hepatocytes on either side of it, these cords, as we call it, or plates. And the blood is modified during that coursing through the liver until it's been essentially detoxified or changed to suit our metabolic needs when it exits into the central vein for circulation. And countercurrent to this, blood goes one way, bile is secreted on the opposite end of these cells into the bile ducts and is secreted into the gut, okay? And therein it's recycled. It's a very elegant system and it's sort of complicated. But what I find so interesting about it is that it's reflected both at the macroscopic level and at the microscopic level. Very few organs do that. So, liver function tests. So it's sort of a misnomer because there's no single test that really denotes liver function. The kidneys kind of have a good single test. It's known as creatinine, you know, and there isn't really a good single test for liver. So there's usually a battery of tests that we have to look at to really interpret what's going on with the liver. And then also the interpretation has to be based on the clinical picture as well. And also any single test is not really good enough. We need to have a pattern. We need to see what's happening over time. So in a way, liver function tests are kind of a misnomer. There is no single test. There's a battery of tests. So they sort of break down into 3 areas. Tests that demonstrate hepatocellular disorder, tests that can demonstrate biliary disorder or biliary injury, and then tests that can demonstrate synthetic dysfunction. And so I'm going to talk about these 3 areas sort of separately as we get into this. So let's talk about hepatocyte damage. So trying to move this thing out of the way here. All right. Close that. So transaminases. So when liver cells are damaged, the hepatocytes themselves, they will release into the blood certain enzymes that are actually only found inside the liver. We call these transaminases to make it simple. Some people call them aminotransferases. There are different patterns in how these can be elevated, and we compare them to each other to help us with the diagnosis of what is going on. And so an example of a very specific one in the liver is ALT. I'm sure all of you have heard of that. You know, when you get a complete metabolic panel, it always has an AST and ALT on it, has an alk phos and other things. But of the transaminases, the one that's most specific to the liver is going to be the ALT. Now, AST is also found in hepatocytes, but it's also found in skeletal muscle. It can be found in heart muscle as well. Not quite as specific, but we do see patterns where one is higher than the other depending on what's going on. So if a patient is having damage to these hepatocytes, you would expect an elevation in AST and ALT, but definitely ALT is more specific. And let's take a look at some of these patterns. So the most obvious dysfunction that we see are patients that have acute hepatitis. So, and by acute hepatitis, I don't just mean viral hepatitis, I mean anything that causes acute inflammation of the liver. So inflammation in medicine is denoted by the kind of the suffix itis. So, so it could be from alcohol, it could be from drugs, it could be from ischemia. There are a lot of possibilities. It could be from a common bile duct stone. But what we see is certain patterns. So if someone has an acute hepatitis A, acute hepatitis B infection, I would expect to see their ALTs higher than their AST. With, say, a Tylenol ingestion or shock, where there's very poor blood flow to the liver and there's a lot of necrosis, as occurs in both of those cases, you might expect variable combination of the two, but very high levels of those labs, upwards of even 5,000 at times. And then for alcohol, we don't expect the levels to be so high, but it flip-flops. It goes to the AST being predominant. And we'll see this also with chronic alcohol use as well. So, and then early on, if there's a bile duct stone, we'll see often a transient elevation all the way up to 1,000 of these transaminases. So that's a good start. You know, if you're seeing elevations in these, and I see this all the time in clinic, where a patient's been referred to us for a evaluation of elevated liver enzymes. Oftentimes, all we see are an elevated ALT and an elevated AST, and you can't really tell much from that. You have to get a thorough history and physical. You have to get imaging. There's so much to it, and you also have to trend it. You got to find out what diagnoses these patients have, you know, and then, you know, you'll learn over time that there are patterns, and you'll get certain clues. You know, the patient that has the clearly ASTs higher than ALT, that maybe didn't tell their primary that when they drink, you know, a drink after work, what they really mean is they drink a lot, you know, and their primary may not know it. But when we see it, we can kind of dial down on it and tell the patient, hey, it looks like your liver is being affected by alcohol. How much do you really drink, you know? Or how much is a glass of wine to you? Is it this big, or is it just this much, you know? People have ways of kind of masking that stuff. So it's very helpful to know the patterns, and it guides your history and your physical exam as well. So on to chronic hepatitis. So, you know, some of the same patterns emerge, okay, but they're just lower levels, okay. One of the ones that's kind of an outlier where it can be quite elevated is in autoimmune hepatitis. We'll often see the ALT can be as high as 800, 900. They're quite alarming to the primaries. You know, we need a biopsy to firmly diagnose this. And sometimes we will get them, you know, put them in the hospital just so we can get everything done. But they don't necessarily need to be admitted when it's that high. But they do need a biopsy so we can confirm it, so we can get them started on steroid therapy. But these chronic hepatitis, you know, hepatitis B, hepatitis C, sometimes you'll see a very low level of ALT elevation, you know, and that's still significant, you know. According to the guidelines, you know, even a level of 40 of an ALT can be significant, you know. So for us, if we know they have these diagnoses and you see a little elevation, it can be worrisome. And particularly hepatitis B. Hepatitis B is one of the ones where we try to wait as long as we can before we pull the trigger on treating it. And so we follow very closely what the ALT levels are doing, what the liver is doing, and because you want to prevent those people from getting liver cancer or cirrhosis. So, you know, as noted, alcohol will still have the AST will be higher. NASH, oftentimes it's flipped the other way, or it can be more equivalent. So it's fascinating trying to figure out what's going on with patients by their liver enzymes. And my lights just turned off. It's those automatic lights related to energy conservation. So in any event, I'm in the endoscopy suite at our surgery center here. It's right next to my clinic. Thought it was apropos. So let's move on to bilirubin. So bilirubin is a major player in liver, both in normal, what the liver does normally, and what happens when the liver has dysfunction. Okay, so where does bilirubin even come from? So there's an indirect type that is not soluble in water, therefore it's not free floating in solution when in blood. It's not free floating, it's bound to albumin. Most of it comes from breakdown products of red blood cell death, and red blood cells only last, 90 to 120 days. They're broken down in the spleen and other places, and hemoglobin is a part of that breakdown, and that heme needs to be metabolized. When it gets to the liver, the hepatocytes take over in that metabolism, and basically the hepatocytes transport it into the cell. They will then conjugate it with a water-soluble component, okay? And then they will try to pump it out into the bile ducts via the bile canaliculi. That's the rate-limiting step there, because it's trying to put more bile into something that's already bile. So it sort of is resistant to that because it requires energy, because it's a high concentration of bile there. So that's the rate limiting step, is excretion there. The kidneys do excrete some bile, okay, and sort of a poor man's test of whether there is some hepatobiliary dysfunction is if you do a urinalysis and you see bilirubin, an abnormal amount in the urine. A little bit is considered normal, but an abnormal amount would suggest that some of that is not making it out properly, for either from hepatocyte dysfunction or something else. And so that's sort of fascinating. I'll sometimes look at the urinalysis to see if it's showing up there as well. So the causes of elevated bilirubin. So the first one we're kind of taught to think of, is there an obstructive process? Is there some sort of blockage to the bile duct? Okay. The most common one being a gallstone. Okay. Gallstones can form, they're concretion, and they can literally block the flow of bile out of the liver. When that happens, bilirubin will rise and go as high as maybe even 30, 10 to 30 is kind of the range. But the kidneys will sort of start to excrete a lot of what it would be out there as well when you get to that level, so it doesn't go higher. Other things that can cause obstruction: mass effects, strictures from previous infections, from previous inflammation, like autoinflammatory type processes, like primary biliary cholangitis from a bacterial source. All these things can lead to strictures and leading to resistance to flow, essentially, and can lead to elevated bilirubins. Additionally, non-obstructive things can do it as well. And we'll often see that it's not just the total bilirubin that's elevated, it's the they're more specific to the liver. They'll have a high direct bilirubin. They'll have a high total, but they'll also have high direct as well. And things that can get at that, toxins like alcohol will cause this. Drug-induced effects, acute hepatitis from all the sources we listed before, acute on chronic disease. So acute on chronic is like the patient that has cirrhosis and then gets an infection and gets sepsis, and then they sort of get an insult to their liver on top of a liver that's already kind of ill. Okay, those are some of the common causes. It's fascinating. Other things that can do it, I think, as I noted before, were mass effects, like tumors also can cause this too. So infiltrative processes, which are pretty rare, but are out there, something to think about. Another thing that can kind of put you more in the direction of the bile ducts as having a pathology would be alkaline phosphatase. This enzyme is actually found in several tissues. So an elevated alkaline phosphatase alone needs to be sorted out, and whether it's involving the liver or something else. You can do an isoenzyme analysis and see if it's originating from the bone. In children, they have higher levels because their bone is developing and growing. It can come from placental tissue in pregnant women. It could be being pathologically released from bone because there's a tumor in the bone. These are things that can cause that. But kind of a poor man's isoenzyme analysis is just to do a GGT, the gamma glutamyl transpeptidase, which is also found on the luminal surface of the bile ducts and the bile canaliculi. So I'll usually do that. I prefer that over the isoenzyme analysis. But when I find this elevation in isolation, I like to get imaging to figure out what's going on with the ducts. I might do an MRCP with an MRI, something like that. At bare minimum, an ultrasound. But there are other things that can cause elevations here. And I didn't list it expressly here, but alcohol is a great example. Drugs, another example. The toxins in drugs can lead to elevations here. And alcohol will also often predominate with the GGT being elevated higher than the alk-phos. So more patterns to look at, more things to wonder about to guide your sleuthing about what's going on with the patient's liver. So like I mentioned, alcohol, drug-related. NASH can also lead to this too. We'll see it with NASH as well. So, and that's kind of the bad form of fatty liver disease. So measures of liver function. So all these things we're talking about aren't specifically measures of liver function, maybe except for the bilirubin levels. I would say the liver is one of the main functions of the liver is processing bilirubin for the body. The other things are just signifying that something is going on at a certain location. Like the transaminases, that something is going on at the hepatocyte level. The alk-phos and the GGT, that something is going on at the bile ducts level or the canaliculi. But measures of actual function of the liver, things like separate of the bile that we already mentioned, the bile metabolism, coagulation factors. All of the coagulation factors are made by the liver, except for 8. Number 8 is not, but all the rest are. Albumin, which is super important, very important protein in our blood. It transports drugs. It transports other things in circulation that are don't dissolve in solution, that need to be bound. and it also maintains the oncotic pressure in circulation so that people have a decent blood pressure. And then there's some indirect measures of liver function we'll get at. So albumin. So when I see an albumin level less than 3.5, I wonder why that's the case. Okay, what's going on? You know, if it's like borderline and we know they have liver disease, then you have to think that there is some underlying, it's not just fibrosis anymore, you know, that they are approaching some significant physiologic changes. And with an albumin less than 3.5, you're going to start having problems, you know, say when it gets to like 2.5, patients are going to have a hard time maintaining their blood pressure. We see this a lot where with people with end-stage liver disease, their blood pressure is so poor that, well, first, it's kind of a transition, you know. They come to us with, you know, on blood pressure medication to keep their blood pressure good, you know, at the right level. They have hypertension in their history, and then as their liver progresses, we have to stop their blood pressure, their antihypertensives. And we try to force the system, you know, we try to get the patients to eat a high protein diet, protect their liver so it doesn't get any worse. But at some point, if the liver doesn't make enough albumin, you're going to have problems with just blood pressure. You're going to have third spacing and edema. The most obvious third space that we see in decompensated liver disease is ascites. And ascites is, I put this picture up because it was color coded just to make it easy. But if you look at it, you'll see that there's a liver that's kind of speckled, and then there's a blue stomach, and then there's a red spleen. And then around all of them, there's this green kind of fluid. That's ascites. And, you know, when the albumin gets low and the liver's cirrhotic, has bad portal hypertension, you know, they just can't, it's very difficult to get rid of that ascitic fluid. We try to limit, you know, paracenteses on these patients and try to use their kidneys to their advantage, you know, by giving them diuretics. But sometimes it doesn't work, and the thing that they really need is a new liver. But we try to keep them going as long as possible, and if you know, sometimes we're able to stabilize them. So yeah, they'll get edema elsewhere too. They'll get edema in their extremities as well. Sometimes they'll get pleural effusions, sort of like ascites in the chest cavity, most often over the liver on the right side. Notable about the albumin, right next to it in the complete metabolic panel is usually globulins. And globulins, the gamma globulins, are made by your lymphocytes in the body and plasma cells, which are kind of a specialized lymphocyte, and they produce immunoglobulins for, you know, immunity. And the liver normally clears a lot of these kind of floating globulins that are in solution, and when the liver starts to lose that functional capacity, you'll see the albumin drops and the globulin goes up. And when they're right next to each other, you'll see it, and then it's a pretty good clue that they're getting significant liver dysfunction from a physiology standpoint. Coagulation. You know, it's interesting because, like I said, all the clotting factors except for 8 are produced by the liver, fibrinogen as well. And, you know, when the liver looks like this, it doesn't make those very well. And furthermore, these patients are at risk for bleeding, you know, not only because of that, but also because they oftentimes have low platelet levels. And so, and then on top of that, they also are at risk for upper GI bleeds because, they'll have varices and portal hypertensive gastropathy. And so, during liver disease, when it's dysfunctioned like this in the end stage, they also are hypercoagulable. But the sum of things is that they're more of a bleeding risk, and that's because their platelets are usually low when they get to this level. And then once they start bleeding from somewhere, which they're likely to do at some point along the way, whether it's oozing or really strong hemorrhage from like a variceal bleed in the esophagus, the body consumes what it has made. And so the clotting factors get consumed, and then there's little to go on, and the body can't stop the bleeding. And this is where they end up kind of in the ER, and then we have to do emergency endoscopy on them, we'll give them emergency drugs, give them transfusions, give them fresh frozen plasma to replace all their coagulation factors, cryoprecipitate for their fibrinogen, and then we're transfusing them blood too. It's sort of a mess, but we're able to usually get a handle on it. And but sometimes you can't, most of the time we're able to. But this is one of the things that we deal with. And the main test that I look at is going to be the INR. I'll look at the INR, and then if they're in the hospital pretty sick, I'll usually get a fibrinogen as well. And I'll have both of those to look at that. So there's, I put this organ slide up, the human organs. So, the effects on other organs is pronounced. I would say it probably doesn't affect the thyroid too much, although we do see some hypothyroidism that shows up, kind of a mild form. But the intestines, there's no lab test really for the intestines to show, but they get like I said, the varices, they get the portal hypertensive gastropathy and colopathy. But in the kidneys, we see real changes in the labs based on the physiology that occurs with end-stage liver disease. And then same with the spleen, what occurs when the portal hypertension gets bad with a cirrhotic liver, the spleen gets big, and we'll see changes. So with hypersplenism, spleen gets large. As it goes from kind of normal size to enlarged, you'll initially see thrombocytopenia. That's platelets that are decreased. And that's another kind of soft sign that there's some serious liver disease going on. You'll see the albumin's a little low, bilirubin's just a little elevated, the globulins are elevated, their platelets are a little low. They're on the low end of hemoglobin, but still maybe normal or just barely abnormal, things like that. We start to see these things, and then you become very suspicious. And later, when it becomes advanced, when we already know what's going on, as the liver function declines, and actually as the portal hypertension gets worse, the spleen will get bigger, and you'll see pancytopenia of all the cell lines. And the spleen it gets swollen because of that backflow. The spleen drains into the liver through the portal vein. And so if the portal vein isn't flowing well, the spleen's going to get big. Then you have this congested spleen. That congestion leads to the blood sitting there for too long, and then the spleen acts on the blood too much, essentially. It chews up the elements, the formed elements. And you'll see, those changes on the CBC. Complete blood count will notice changes when they have liver disease. The kidneys, this is huge for us. When they're cirrhotic and the portal hypertension gets worse, you'll have vasodilation, which leads to a decreased blood volume effectively, and this leads to a big cascade of responses from the kidneys. The kidneys go into overdrive to kind of fix things. They're trying to fix things. And it leads to problems. And this is, one of the reasons why the MELD score includes several kidney factors on it. MELD score for liver transplant, for assessing, their risk of mortality and by proxy, their need for a liver, how badly they need one. I mean, sodium level is on there, creatinine is on there, whether they're getting dialyzed or not. Those are all things that are questions on it. And it's driven by these normal responses that the body is having to this abnormal physiology. Aldosterone gets oversecreted, they start retaining sodium. With the sodium retention, water wants to stay in circulation. Then there's no albumin. There's a low albumin in circulation. Then that water then leaves the blood and goes to third spaces. And then through AVP in the kidney, it also reclaims just water specifically. And then to try to maintain pressure to the kidneys will constrict the blood vessels there, and that leads to essentially poor blood flow to the kidneys, and then can lead to hepatorenal syndrome, which can lead to essentially end-stage kidney disease as a result of this. So it's fascinating how important the liver is, and when it goes bad, how it affects other organs. Now, when they have hepatorenal syndrome, the acute version, their mortality goes up significantly, about 50%, so if not more. So we'll see abnormalities in urinalysis. Some have already noted where you'll see bile in the urine. A lot of times we see red blood cells in the urine as well, that goes with some of the clotting issues that we talked about. Another kind of indirect marker of the liver's function is ammonia in the blood, all right? And ammonia comes from several things. You get it from your gut, from other aspects of metabolism in your body, metabolizing proteins. And normally what happens is it's converted from ammonia into urea. Urea goes into the urine. Well, when the liver doesn't work properly, then that ammonia makes its way into the bloodstream. And then it goes to the brain. Brain tries to get rid of it. And basically combines the ammonia with glutamate to create glutamine. Glutamine then leads to swelling of the brain, which leads to hepatic encephalopathy. So when you see an elevated ammonia level, the liver is not doing its job properly. It's not doing its job. And it becomes pretty bad when we have to do a portosystemic shunt. That's where we divert flow from the portal vein because of the severe portal hypertension into the hepatic vein, basically bypassing the liver. Then we really see higher levels of ammonia, and the patients are at higher risk for hepatic encephalopathy, although it solves a lot of their ascites problems and protects their kidneys to a degree. So in any event, this change to elevated levels of glutamine in the brain leads to swelling. They can be so severe that the patient will become comatose. And there's 3 causes of death in end-stage liver disease that we are on the lookout for. One is GI bleed, severe infection, and then hepatic encephalopathy. And when it gets very severe, if it's not managed appropriately, it can kill the patient. And on the way, we'll make them comatose, and then we have to assess the brain to make sure that it hasn't herniated. So the liver dysfunction there ends up affecting the brain as well. So in summary, the liver is a complicated organ, very fascinating. There's always something to learn about it. There's no single test that represents liver function, and for that matter, liver damage. all right? Because some of the tests that we look at are more markers of possible liver damage and aren't really representing function. So it's sort of a misnomer. And then, you know, as liver function declines, particularly in the setting of severe cirrhosis, which leads to portal hypertension, we start seeing a lot of other laboratory abnormalities that come up as well, and these affect other organs. So with that, thanks for having me. Thanks for letting me give you this talk. I hope it was educational. And let me see how we go from here.
Thank you so much, Dr. Sweet. If anybody has any questions, please, just wanted to remind you to put them in the chat. Maybe I could ask you a question, Dr. Sweet. So what can patients do, you know, themselves to sort of monitor whether or not, you know, they may have something wrong with their liver? Is there anything that a patient can do to, you know, alert them that maybe they need to see their doctor and ask them to get a liver function test?
Yes. So, I mean, the biggest one, which has been described as far back as Hippocrates, is jaundice. So, you know, with the lighter complexioned individuals, it's easier to see that in the skin. But if you have, you know, if you have a darker complexion, or in some people, it's impossible to tell by looking at their skin. But the way to kind of bypass that is to look at the whites of the eye, called sclera, the whites of your eye. And if you notice, or others notice, that you have some yellowing of the eye, that means that your bilirubin your total bilirubin is probably starting to be higher than 3. That's when we usually start to see jaundice, is when bilirubin is higher than 3. And that would be a sign. You know, telangiectasias, these little spider veins, erythema of the palm, palmar erythema, so redness of the palms, and then these little spider veins that people will sometimes get on their chest, on their arms. Those are markers, kind of signs, if you will. But as far as you know, that's probably your best one that you could see on your own. But patients will have fatigue. They'll feel fatigued. We see this a lot with our hepatitis C patients, that they'll have just fatigue and maybe a vague pain where their liver is. We'll sometimes see that with our fatty liver patients when their liver is quite large, or that. So yeah, so those are kind of, did that answer your question?
Yes, that was excellent. Thank you. And we do have one other question. Are clay-colored feces a sign of liver damage?
Clay-colored feces. So, okay, so that's an excellent question. So that's more of a sign. That's a good one. So this also goes back to Hippocrates. So clay-colored stools is a classic indicator that the bile is not making its way into the gut. All right. So if you have severe cholestasis, you know, you could see that kind of discoloration, but more poignantly when it's from the common bile duct being blocked by a stone. Now, these patients will present typically with abdominal pain that's sort of severe, right upper quadrant abdominal pain, but not always. I mean, there is, you know, pancreatic head cancer can put pressure on the bile duct and stop flow, leading to that sort of backup can also lead to clay-colored stools and not be super painful, you know. Any other questions?
Great. I don't think so. I think that concludes our webinar, and I want to thank you very much, Dr. Sweet, for that comprehensive analysis of the liver, and hopefully everybody got a takeaway from that excellent summary of our liver.
Sure,
so thank you again.
Pleasure. Thank you so much.
Yeah,
thanks for having me.
Thank you. And everybody have a good night.
Good night.